Our next topic is GERD, gastroesophageal reflux disease in children and in infants, because in infants, the lower esophageal sphincter is immature and the esophagus is short and narrow, and their diet is mainly liquid diet, and they are mostly in a supine position, so they are at a risk of developing GERD. So how a patient of an infant with GERD will present to you? Usually a less than 1 year old child with non-projectile vomiting after feeds. So the vomiting is non-projectile. Non-projectile vomiting after feeds, immediately after feeds, gags, drops after feeds. Because of regurgitation of the feeds, he gags and chokes after feeds, and he is usually irritable, crying, and difficult to feed. And failure to thrive is usually present, but not always. What is the treatment of GERD in pediatrics? What are the features of GERD in pediatrics? The features include non-projectile vomiting after feeds, or gags, chokes after feeds, or crying or difficult to feed. Or an 8-week-old exclusively breastfed infant is brought by his mother into the GP with the following symptoms: vomiting small amount of milk after most feed, refusing feeds and crying shortly after feeds. So this is a hint for GERD, that is vomiting small amount of milk after most feeds, or vomiting immediately after feeds, refusing feeds and crying shortly after feed. He is on the 50th percentile for height and weight. No flattering of growth. What is the most likely diagnosis? So remember that if a child who is less than 1 year old present to you with vomiting after feed, or there is gag, choke, and after feeds, then your diagnosis will be gastroesophageal reflux disease. First line treatment is to assess the breastfeeding and advise the mother to increase the frequency and decrease the amount. If no response with it, then alginates such as syrup Gaviscon can be tried. And the second line drugs are EPPI or H2 receptor blocker. A trial of these drugs should be given for 4 weeks. Gastroesophageal reflux disease resolves spontaneously with time, mostly by the age of 1 year. Another example, baby vomits shortly after every feed, cries, sometimes refuses feed. The growth is sometimes normal and sometimes affected. So this was all about gastroesophageal reflux disease in pediatrics. Now our next topic is necrotizing enterocolitis. Now what is necrotizing enterocolitis? Necrotizing enterocolitis is basically necrosis of the enteric tract. Necrotizing enterocolitis. Remember this triad, that is abdominal distension, vomiting, and bloody stools. Prematurity is the main risk factor for necrotizing enterocolitis. Now, what is the cause or pathogenesis of necrotizing enterocolitis? Necrotizing enterocolitis has multifactorial causes. One of them is intestinal immaturity and microbial dysbiosis, that is overgrowth of the bacteria. Now, intestinal immaturity leads to compromised intestinal epithelial barrier. So when this epithelial barrier is broken down, what will happen? Inflammation of the enteric tract will happen when this intestinal epithelia is disrupted. Then lumina is exposed to microbiota, which can lead to inflammation and sepsis. Other causes of necrotizing enterocolitis include too little oxygen or blood flow to the intestine at birth or later, which result in injury into the intestinal lining, and heavy growth of bacteria in the intestine, which result in necrotizing enterocolitis. So remember these three, the triad of these symptoms, that is abdominal distension, vomiting and bloody stools, and remember the risk factor as well, that prematurity is the main risk factor. So a neonate with abdominal distension, a premature neonate with abdominal distension, vomiting, and bloody stools. So can somebody tell me which respiratory condition is common in premature infants?
Bronchiolitis.
Bronchiolitis in premature infants. The hint is that that disease has something to do with prematurity.
Is it RDS?
But yes, respiratory distress syndrome. That's right. Excellent. Respiratory distress syndrome is common in premature infants because of underproduction of surfactants. So now we know another condition, another GIT condition that is common in premature infants, and that is necrotizing enterocolitis. So if a premature infant present to you with abdominal distension, vomiting, and bloody stools, then your diagnosis, you will suspect necrotizing enterocolitis. So two risk factors are most important for necrotizing enterocolitis. One is prematurity is the main risk factor, and there is an increased risk when empirical antibiotics are given to infants beyond 5 days. So excessive antibiotic treatment and prematurity are the two most important risk factors for necrotizing enterocolitis. So in the question, one of these or even both of these risk factors will be mentioned along with triad of abdominal distension, vomiting, and bloody stools. The diagnosis will be confirmed on X-ray, which will show distended loops plus air in the bowel wall, which is known as pneumatosis intestinalis or intramural gas. Air in the bowel wall, that is pneumatosis intestinalis. Now let me show you an X-ray. So what is pneumatosis intestinalis? You can see the dilated gut loops on this X-ray. They are very visible. You can clearly see these dilated gut loops in this X-ray. So dilated gut loops, and you can see that this is here the liver is lying, and you can see these black lines in the liver. This is basically portal venous gas in the portal venous system. So one sign is that there's gas in the portal venous system, and the second sign is that there will be dilated gut loops, and the third sign is that there will be intramural gas or air in the bowel wall, which is also known as pneumatosis intestinalis. So let me show you what is pneumatosis intestinalis. You can see that these white lines, they basically represent the wall of the bowel or enteric tract. You can see that this is a single line, a white line that is representing the bowel wall. Here you can see that this line is split into two. There is one line going like this and one is this. And between these two white lines, there's a black shadow. So this is air in the bowel wall, which is also known as pneumatosis intestinalis. Another example is here. You can see that this is a white line which represents the wall of the bowel. And you can see that this line is splitted here. One is going here and one is going there. And in between these two lines, there is a black shadow. So this is air in the bowel wall or pneumatosis intestinalis. So a premature infant or an infant, a premature neonate or a neonate with a prolonged use of antibiotics beyond 5 days who present to you with abdominal distension, vomiting and bleeding per rectum. And there is pneumatosis intestinalis on X-ray, or there is gas in the portal venous system, or there is dilated gut loops on X-ray, then your diagnosis will be necrotizing enterocolitis. Now, what is the treatment? So the diagnosis of necrotizing enterocolitis is confirmed on X-ray, and the treatment is we need a total gut rest and total parenteral nutritions are used. If there is no perforation, then total gut rest and TPN along with antibiotics. Plus, babies with perforation will require laparotomy. The feet, start IV fluids, perform abdominal films, and start systemic antibiotics if there is no perforation. And if the perforation is present, then we need to do laparotomy. Then we need to surgically correct the perforation because perforation cannot be closed with medication. So remember the mnemonic ABCD: air in the bowel wall, bloody stools, cannot tolerate feeds, distended abdomen. Initial investigation is abdominal X-ray, blood film and culture, and coagulation studies can also be done. Initial step is to stop feed, NG tube, NG decompression, fluid and electrolyte balance, and antibiotics such as penicillin, gentamicin, gram-positive cover, gram-negative cover, and anaerobic cover in the form of metronidazole. So if air in the peritoneum is present, then we will do surgery. Remember that air in the peritoneum is known as pneumoperitoneum, while air in the bowel wall is pneumatosis intestinalis. These are two different things. If there's only air in the bowel wall, then you will conservatively treat the patient. And if there is air in the peritoneal cavity, then we will do a surgery. Air in the peritoneal cavity means perforation has occurred. So it's important to remember these points. So this was all about necrotizing enterocolitis. I hope it's clear, everyone.
Can you repeat this last part, please? The pneumoperitoneum.
Pneumoperitoneum means air in the peritoneal cavity. Peritoneum basically is the lining that is lining the GIT tract. So if air is present in the peritoneal cavity, then we will do surgery. The presence of air in the peritoneum means the gut wall has perforated. So the air leakage into the peritoneal cavity, which is known as pneumoperitoneum. While pneumatosis intestinalis is air in the bowel wall and not in the peritoneum. So if pneumatosis intestinalis is present, then we'll manage it conservatively with NG decompression, fluid and electrolyte balance, and antibiotics. But if perforation or pneumoperitoneum is present, then we'll treat it with surgery.
Right. Okay.
Now some points about diarrhea. History of travel, watery diarrhea, weight loss, abdominal pain, foul smelling flatulence and blotting, GIDSs. Remember that history of travel, if someone developed diarrhea after a travel history, then you will think about two diagnoses. One is GRDSs and the second one is E. coli. Then what is the difference between E. coli and GRDSs? You need to remember 2 points. One is that if the diarrhea is chronic, then it is GRDSs. If diarrhea is associated with weight loss, then it is GRDSs. While the diarrhea that is caused by E. coli, it is self-limiting and it usually resolves within 2 to 3 days. While the diarrhea that is caused by GRDSs, it persists for more than a week or even 2 weeks. And there is weight loss associated with GRDSs, while in case of E. coli, there is no weight loss. So remember these 2 points to differentiate between GRDSs and E. coli. So if you're suspecting GRDSs, the first line investigation will be stool microscopy for ovine parasites. And another investigation would be stool ELISA or PCR. Because Giardia lamblia is a protozoa, so metronidazole is the first line treatment. A patient came from Kenya, develops watery diarrhea with abdominal cramping. The most likely organism is E. coli. A patient came from Kenya, develops watery diarrhea with abdominal cramping. He also have foul smelling, flatulence, and weight loss. So you can see that in one scenario, there is no mention of weight loss. And in the second scenario, there is mention of weight loss. So whenever you see weight loss or the duration of the symptoms more than a week or more than 10 days, then it will be Giardia. Because traveler's diarrhea that is caused by E. coli is short period and self-limited. Now again, another diarrhea with a history of travel. History of travel followed by a prodrome, that is high-grade fever, headache, myalgia, followed by bloody diarrhea. Then the causative organism will be Campylobacter jejuni. So history of travel with diarrhea that is in which there is initially a prodromal period plus prodromal period is followed by bloody diarrhea. Then our diagnosis will be Campylobacter jejuni. Now, what are the other organisms that can cause bloody diarrhea? They are Salmonella and Shigella. If someone develops bloody diarrhea after eating eggs or chicken, then your diagnosis will be Salmonella. And bloody diarrhea that is associated with the prodromal period after a history of travel will be Campylobacter jejuni. And if Campylobacter jejuni is not given in the option, then you can select Shigella as well. Now, the most common cause of diarrhea in pediatric is virus, that is rotavirus. Diarrhea that is associated with weakness and areflexia, Guillain-Barré syndrome. Diarrhea with renal impairment plus hemolysis, hemolytic uremic syndrome. Diarrhea followed by right upper quadrant pain, amoeba. Another hint for GRDSs is that watery diarrhea after camping or long travel in Europe. So history of travel to the Europe or history of camping and watery diarrhea, your diagnosis will be GRDSs. Diarrhea that develop after long-term antibiotic use is caused by Clostridium difficile pseudomembranous, also known as pseudomembranous colitis. And the treatment for pseudomembranous colitis is oral metronidazole or oral vancomycin. According to the latest guidelines, oral vancomycin is now the first line drug to treat antibiotic associated diarrhea or pseudomembranous colitis. Now, a diarrhea that occurs hour after a meal, a diarrhea that occurs 3 to 4 or 5 to 6 hours after a meal, it is caused by Staphylococcus aureus. And diarrhea in a bedridden patient is caused by fecal infection. Remember that bloody diarrhea is caused by Campylobacter, Shigella, and Salmonella. So this was all about GIT disorders in pediatrics. I hope it's clear to everyone.